Hello and welcome back to our last session for today, where we will be discussing about ethical issues. Our first talk will be on ethical issues in a pandemic. How can we prepare better? Which will be given by Dr. Tan Hui Siu. Dr. Tan Hui Siu graduated from University Malaya and obtained her RCPCH professional degree in 2010. As a former head of two pediatric departments, she contributed to several national guidelines and health systems. She was awarded the Yayasan Khazanah Scholarship to pursue a Master of Bioethics at Harvard. Currently, she concentrates on developing clinical ethics services in Malaysia. Hospital Ethics Support Service in Ampang was established in 2020. As Malaysian Bioethics Community co-founder, she led the editorial work for bioethics and COVID-19 guidance for clinicians, and with several MOH clinicians released best practice in clinical ethics and compassionate care last year. Hui Siu is a Malaysian Research and Ethics Board member, and her interests include social advocacy, cross-sectoral collaboration, and healthcare leadership. Let us welcome Dr. Tan Hui Siu to the stage.
Hi, I'm Aisha. How is everyone? Thank you to Hospice Council of Malaysia for the invitation. I was given the task to speak on the topic ethical issues in pandemic. How can we prepare better? As I was feeling for the past 2 years as one of the 6 blind men and the elephant, and was frustrated with how much I was kept in the dark about why some things were happening and why some were not. Nevertheless, from my location and point of view, I was able to survey the landscape by putting myself right into some of where the actions were, being in charge of the isolation wards and was part of the COVID-19 hospital committee. I was sitting with the MOs in the WhatsApp groups, heading to ethics platform, providing ethics consultation, engaging 60 to 70 groups and individuals in my 12 to 13 working hours every day. There was definitely limitation as to how much information I was privy to or able to discuss openly and how much energy and time I was able to focus on all areas. As I speak, I'm mindful of the groups and organizations that I identify with, and this talk makes no claims about the best evidence, clinical tests, methods, or calculations. Ideas and opinions remain mine alone. Case scenarios are semi-fictional, and data shared are known publicly. In general, I believe that we could have done better by having a crisis standards of care, better communication at various levels, and in the handling of death and dying. These are the main themes for today, although it would be my pleasure to share my thoughts on other areas as well. And so the issues and how we could have done better include addressing moral distress, having crisis standards, defining and managing death and dying, and redefining compassionate care. So the best place was to start with what the clinicians were going through, what they were struggling with, what were they feeling. And as we pay more attention to the voices of the clinicians who are managing the pandemic at ground zero, we noticed that definitely there were tensions between the patient-centered approach of clinical care on a normal day and the public-centered approach of clinical care during the pandemic crisis. And this shift to patient care for public health interests include the need to abide to infection control measures, juggling optimally between COVID versus non-COVID patients and their care, and also the unfamiliarity to deal with disaster where resources have reached a limit and triaging is needed to save the most lives. To further illustrate these challenges, there is not only the particularity with COVID-19 in terms of transmission, rate of fatality, and viral evolution, but there is also the issues with pre-existing social and health disparities among different groups of population, which goes by gender, level of education, IT accessibility, social, cultural, and language differences, and other social political determinants of health. That explains when and where patients present and how they navigate the health system during the pandemic. On the other hand, the culture of medicine and its pre-existing shortcomings were not of any advantages during a pandemic of this scale. Not only there were the tensions between the focus on individual patient and the focus on community, there was no crisis standards protocol in place and the agreed threshold for triaging and how to go about it. There were huge gaps in the skills and competency in terms of decision-making and communication in handling ill and dying patients among the doctors, and the COVID-centric focus by the ministry had played a role at times in an overzealous infection control measures when the evidence has later shown that we should be changing. When healthcare professionals and administrators were thrown in such a crisis, we were hoping to see more humility, to acknowledge our limitations and uncertainties, but still be able to be confident in some areas. We can't blame clinicians who were overwhelmed and feel very distressed for 2 years just to share some of the distress caused. Several physicians have been asking for practical guidelines to help with difficult clinical decisions, such as ICU triaging, risk of CPR, visitation, confidentiality, communication, palliative care, moral distress, psychosocial aspects of staff. A guide during COVID-19 can help physicians because hard, unfamiliar decisions are being made rapidly every day, and distress in the process is normal. Do you have a written guidance for ethics, especially designed for Malaysia's circumstances during COVID-19? If you have one, kindly share with me, as you understand Malaysia's unique for our diversity, economical circumstances. Hence, the clear guidance is utmost importance. We don't want a bias, misunderstanding, misleading, misinterpretation of doctors' deacons, and hopefully none will manipulate it that can spark any hate and disharmony among us. And so when we look into this distress cause, we can classify them into moral distress, which is a perceived violation of one's core values and duties, concurrent with the feeling of being constrained from taking the right action. MD should be treated as a separate entity, although not mutually exclusive from psychological distress, which describes emotional reactions to these situations and not always value or principle in context. During COVID-19, moral distress could be due to changes in clinical decision-making and standards, changes in patient-physician relationship, limited chances for usual compassionate care, and conflict of obligations towards self, patients, colleagues, and families. MD is key to where we could focus and knowing how should we start and knowing where we could be doing better. It is important to always ask if it's just a psychological distress. Is it really impossible to act, or is it really a moral issue in the first place? Cumulative moral distress can lead to burnout. And when we look at a constraint, institutionally includes lack of preparedness and responsiveness in pandemic, lack of guidelines, lack of limited human resource, and ineffective communication and dissemination of information. On the other hand, there is the competing obligations that becomes a constraint when there are concerns about transmission of virus from self to family. Dr. Sharon and a few bioethicists has recently published some of these voices through a qualitative study among clinicians at University of Malaya. And these were the themes that they had identified. They recommended that the need for clinical ethics consultation services in hospital is needed to navigate the various ethical dilemmas during a pandemic. On the other hand, Dr. Sheila and a few others has taken up the project on focusing on moral distress among frontliners in several hospitals in Malaysia and what were the root causes. Sharing the preliminary results with her permission, almost 500 samples were collected and 2/3 were from the nurses. Her team found that doctors scored higher for MD scores, and the potential causes were an experience of compromised patient care due to lack of resources, the requirement to care for more patients than they could safely care for, and the excessive documentation requirements that has compromised the time spent on patient. As for us, for the critical 3 months, May to August 2021 last year, we had 76 cases with ethical dilemmas and distress that were referred to us at the ethics consult, And you could see here that the cases referred has increased when the numbers of deaths shot up. The average age of cases that has been referred has also dropped, along with an increased moral struggles of deliberating the decisions for younger and younger patients. When we look at these cases, there were 126 ethical issues identified, and many revolved around best interest issues, end-of-life care, and also social justice and resource issues, which were all closely related, but not particularly seen in terms of resource allocation pre-COVID. I believe that moral regrets, which is something that lingers when you had no choice but to choose, even when there is no right choice in sight, could be overcome by notifying in advance, apologizing, compensating, and also changing the circumstances for the future, as what we are doing today. And here, Dr. Sheila and I came up with some solutions to manage the moral distress during pandemic, which you could access through the QR code here. Next, I will share with you, ladies and gentlemen, the importance of having crisis standards of care laid out before any crisis or disaster. What we need is a disaster protocol. And sharing here from the Institute of Medicine guidance of establishing crisis standard of care for disaster. A crisis standard of care protocol is needed when there is a substantial change in the level of care it is possible to deliver due to a pandemic or disaster. The formal declaration that crisis standards of care are in operation should enable protections for healthcare providers in the necessary task of allocating and using scarce medical resources. And the foundation of crisis standard of care planning comprise ethical considerations and legal authority, as illustrated in the diagram here. CHES has published an article on triaging in 2014, and some of the recommended points include that a system must be established in advance. A triage policy based on improved incremental survival rather than first come, first serve. Triage protocols, clinical decision support systems, rather than clinical judgment alone, should be used in triage whenever possible. Technology should be leveraged in triage, and the use of inclusion and exclusion criteria couldn't be more emphasized. And the need to reassess patients after a suitable time should be decided, such as 72 hours. And another illustration from the same article, the authors shared that the response to the disaster surges may vary from a conventional response where critically ill patients are managed with no significant changes in the standards of care, to a crisis response where resource limitations decide substantial alterations in both the standards and the processes of care to provide minimum basic critical care to a maximum number of patients. The author said, the prioritization of patients for the urgency of treatment occurs at all stages along the continuum. However, there should not be confused with the meaning of triages, which includes prioritizing patients for care, meaning which patient receive care first, but also rationing scarce resources and making decisions about who will and will not receive potentially life-saving therapies. Let me show you an overview on the concepts that inform a crisis flow that we drafted later. Internationally, most triage protocols are still institutional based. Some exclude, some include patients first. When deciding for ICU admissions, we have more or less agreed for Malaysia that it's better to include all, exclude, and then decide on prioritization. A few bioethicists had also proposed a triage committee to calculate scores and review logistics and feed to clinicians as to reduce bias and also the moral burden. These protocols use many types of clinical criteria, and there are different ethical considerations for this criteria. For instance, short-term prognosis consideration is more objective and less biased, but will create many with the same scores, and tiebreakers must exist to decide for the second round. WHO suggested that it should be individualized, and for Malaysia, we have mixed both short and long-term criteria apart from likelihood, benefit, life expectancy, quality of life, and patient wishes. First come, first serve should always come at the second level of consideration. So the proposed safe and ethical triaging for COVID-19 was actually proposed by Malaysian Bioethics Committee in May 2020, 2 years ago, that applies both clinical and ethical consideration and serve as a good flow for clinicians. It says here that the time and opportunities to deliberate on the decision to withdraw care through an informed decision by the patient, team decision, team consensus, and family conference may not be present during a crisis. Thus, ethically, it is acceptable to consider a different flow of decision-making, which is safe, transparent, and just. So at the beginning of year 2021, last year, a small group of clinicians, including me, we worked on an operational flow, and we deliberated on the threshold of activation, potential models, formulation settings, coined a few terms, and proposed a crisis decision-making support pathway that was not far from previous practice. And this discussion include looking into pre-existing concepts and models as references. To develop something for Malaysian hospitals, it is essential that any system should aim for safety, fairness, transparency, and being supportive. I believe we need to decide when to activate a crisis flow, what clinical criteria to use, and if it should focus on short-term prognosis, as in mortality risk, or include long-term prognosis, with or without the help of objective scoring. We need to know when there is much individual variability of clinical assessment and criteria, and for governance reasons, it might be best to make it that specialists makes most of the critical decisions. For fairness, we need to agree that decisions will not be based on social status. It will be systematic and consistent across the board and across the time, as what we have agreed with appeal and dispute resolution in place. It needs to be transparent, and all stakeholders' input is sought with a commitment to regularly review and audit. And lastly, it needs to be felt as supportive to all stakeholders. Any flow will roughly include the 6 domains: inclusion and exclusion, a level of decision-making, time breakers, reassessment exit plans, crisis governance and oversight, and dispute resolution and risk management. By mid-year 2021, there was a release for the clinical criteria from Malaysian Society of Intensive Care. The clinical criteria were completed and it was presented to DG, a flow for crisis, for critical crisis decision-making support pathway for Malaysian hospitals. This flow is a solid clinical consideration that includes and excludes, with assessment and decision-making at a specialist level, especially to decide if a patient will not benefit from intensive care admission. There are suggested resolution pathways at the hospital level, and ideally with ethics and legal facilitation in the presence of disagreement or complexity. A proposal of other supportive systems include palliative care support, empathetic communication, and compassionate care steps were included. There were reassessment exit plans for patients who do not respond well despite all effort. It definitely emphasizes oversight and other clinical governance measures. You could find the chapter for full explanation of the flow from the QR code here. As we can't avoid talking about palliative care during COVID-19 as part of the standards, it is a must to understand that palliative care should be provided to any EU patients, regardless of the direction of care. And though there is a risk of mistreating it as a blanket order for conservative management by other team members, when instead active care and monitoring should still be continued, this fear has caused the avoidance of clinicians to consider palliative care or even do the most ethical thing, that is to manage symptoms optimally. So some of us had to reframe palliative care to intensive symptoms management for EU patients, regardless the direction of care, in general wards and in the ED. And that pain and dyspnea must be managed adequately, even though some has equally cry of providing that the provision of adequate oxygen ventilation should be provided instead. It is definitely challenging and one of those dark moments that many of us had on the ground. Next, we'll be looking at maintaining truthfulness, and truthfulness was needed to fulfill many of the principal values for crisis. Includes duty to care and plan, fairness and equitable access to care, accountability, inclusivity, transparency, reasonableness, responsiveness, and solidarity. Healthcare professionals, providers who manage COVID-19 patients on the ground have the right to actually advocate for truthfulness in the figures from the leadership, figures that matter, figures that depict the reality on the ground, figures that help makes the right changes and encourages deep reflections. Let us not forget that it is not it's not distance memory a mere 1 year plus ago that an estimated 22,000 Malaysians died from COVID alone and died at many times alone. I'm unaware if there is a proper inquiry into these deaths, which I think we should, and many answers were needed in terms of age, demographics, where and how patients die, and if there were systemic or medical preventable factors. When I was looking for these answers on the internet, the only information I could find was on the KKM Now with only latest 6 months statistics. The Department of Statistics Malaysia did release the national stats of deaths for 2021, with again a very simplified infographics with percentage rather than the number of COVID deaths, and without much inferential analysis to guide future changes. And I was specifically drawn to the fact that if the dominator was the total COVID deaths, there is a relative disproportionate higher rates of deaths among some ethnicity groups. So when it comes to the governing authority and the public, there is an accountability and trustworthiness arguments when the state needs to be truthful with their figures during a crisis. But we were aware that risk communication requirements also means that at certain times there is a need to publicize some figures more effectively to promote precautions, and other times to be careful with how some figures cause unwarranted panic in the society. We definitely need risk communication experts to ensure that we achieve the right balance between truthfulness and risk communication. However, in the internal systems, it is important for leaders to actually collect and report figures that could show the real-time struggles by the clinicians. Knowing the true numbers not only promotes transparency, but also efficiency, as we could revise the admission and discharge criteria and how patients could seek medical attention quicker, example, walk-ins directly into the hospital. Leaders and managers need to know the right numbers to be able to act quick enough to manage such capacity, to make changes in patient flow, risk communication, and lastly, to promote team cooperation and unite healthcare providers. On the other hand, some issues do not need figures to justify the attention, and at times figures do not really persuade more attention and changes at a high level, and this include palliative support for end of life, psychological and moral support, and patient and family support. Let me share with you some examples. You could see here that the periphery COVID Cat5 cases that were reported daily in a hospital in the mid of 2021 were having some changes a few months later, when only those which were ventilated in the open wards were reported, dismissing many more Cat5 patients that were supposed to be given the attention that they were supposed to benefit from ventilation and ICU admissions. One hospital here did a better move by capturing all its Cat5 patients, regardless of location, into its ICU data to give a true figure. Another good example from another ED that captures and reports not only the bed and equipment capacity, but also oxygen utilization. So between what feels good, ladies and gentlemen, and what is right, local administrators are under pressure to frame better numbers, partly due to political pressure, but also the demanding expectation to explain the steps that they have taken to resolve the issue. That may also explain the discrepancies between what is reported in the media and those that were announced by the highest level in the ministry. Needless to say, and sadly to say, whistleblowing in the media became the most effective way in pushing for immediate changes. And this vicious cycle was caused as decision makers focused only on media highlighted areas rather than going to the ground and checking on all areas and demanding that true figures that show the reality on the ground. Next, from an ethics point of view, an observation, there's still a huge gap among clinicians dealing with the decision-making, communication, and managing death and dying in terms of their skills and competencies. Here, I try to map out some of the potential challenges and barriers in making end-of-life decision before COVID, which include there is lack of patient empowerment, lack of family conversations of death and dying, in terms of medicine, that it is hard to die, and there is a focus on tertiary care. In terms of clinicians, not only the issues with skills and competencies, but also a lack of support for them and unwarranted litigation fear from family members. So, and when the COVID came, with the time pressure of critical bedside decisions to be made, changes in the practice that we have, having to manage the public health emergencies within the walls of hospitals, it has definitely strained healthcare providers as they lack the skills and competence. For one, there was this confusion with terminology and different interpretations in terms of DNR, DNA, CPR. It is important that we are clear about the terminology of which DNA, CPR, or DNAR denotes more specifically for cardiopulmonary resuscitation, especially in the face of futility, not as a blanket order for conservative management or withholding all other life-sustaining therapy. And thus, end-of-life decisions must be discussed, decided, communicated, and documented in specifics, and especially in the overall direction under the goals of care. It is rarely appropriate to discuss DNR decisions in isolation from other aspects of care. After disclosure and aligning expectations where patient is deteriorating or fulfilling the criteria of futility, discussion should revolve around the discussion on the goals of care, which includes setting of care, medical and nursing care, resuscitation, and symptoms management. So it is good that we specify what is involved in the decisions and also communicate appropriately. So when we tried and draft a flow, and you could see that if once you have the trigger that in terms of DNR, you should be assessing what were the indications. Were the patients having, not responsive to treatment and continues to deteriorate with clear signs of irreversible organ failure? And with this assessment, was it done at a correct level of decision making, followed by disclosing the bad news to the family, letting it sink with them, and aligning the understanding and expectations before discussing with them the direction and the specific plans for the patient. It is often a process, and communicating straightforward decisions are acceptable. Next, to make sure that the necessary steps of management is in place and to resolve any confusion and disagreement if there were any. Last but not least, the areas with compassionate care. Many of us feel that we are still not doing well in terms of knowing how to define compassionate care during the pandemic. And the most disturbing issue is still dying in isolation, and the allowance of physical presence were only noticed at the tail end of the pandemic when our new minister took over. And some of us tried to formalize a virtual visitation in all wards, ICU and EDs. Tablets were available in all wards for these purposes, and SOP were drawn up to support the practice of virtual visitations when physical visitations were not allowed. We hope that hospitals and physicians do consider physical presence with the following justification, especially for those critically ill, dying, and also close family members of frontliners. These justifications include it reduced the overall burdens, psychosocial, mental health, from public health measures and isolation restrictions. Many of patients are dependent, and as when the families are not there, nursing are not adequate, many of them ended up on CBDs, IV drips, physically restrained and not monitored. And they end up with more deaths and also unwarranted incidents such as suicide, abscond, aggressive behaviors. Patients were not presenting at all or presenting earlier enough because of this. And thus, family members' rights and patients' rights should always be balanced with the evidence of transmission risk. In terms of family, if family presence were in place, they have better closure as they witness everything has been done. It helps to offload nursing work, and healthcare workers feel relieved and prevent further moral distress from seeing that patients were dying, struggling alone at end of life. In fact, many countries have revised their policies, including NHS, as there is potential ethical and legal implications for not providing it, ladies and gentlemen. So with that, I would like to end my talk today, and I thank you and wish you all the best. for 2021. Keep safe and take care. Thanks.
Thank you so much, Dr. Tan Hui Siu. I think we've just learned so much from the pandemic and um, the suffering that has caused, that has been caused to many patients and families, and I think has definitely shone a light onto the importance of palliative care just throughout this pandemic. Hopefully, we don't have another pandemic, but hopefully, it gears up, our whole fraternity and even other medical fraternities to provide the best care for all our patients. Okay, we will now go on to the next talk.